I'm Dr. Manwai Lee from Ipoh, Malaysia, and today I'm going to talk to you a little bit about anterior vitrectomy, and really not so much how to do it, but more so looking at how you can control the different modes and settings on your machine. So understanding vitreous is very important before you actually start doing anterior vitrectomy. You must realize that the vitreous body itself consists of a lot of collagen fibrils, and really what you don't want to do essentially is to pull on vitreous, because obviously that causes traction on the retina, and the worst thing is to go after vitreous and causing retinal detachments and giant retinal tears, which I'm sure your retinal surgeon will be very happy to do, but it's something that we don't want an outcome for the patient. So understanding the vitreous anatomy is important. Now, the other thing is understanding fluidics. I think fluidics is something that we are familiar with when we do phaco surgery, but again, fluidics are also in play when we do vitrectomy. The principles of anterior vitrectomy I'm going to highlight, and what we want to do is to minimize intraoperative vitreous traction, as I mentioned. You want to prevent postoperative vitreous traction, and you want to maintain a pressurized globe at all times during anterior vitrectomy. So the balance of inflow and outflow is crucial. So looking at the settings, again, this is referring to the Centurion machine. And do we understand what this all means on the screen that's facing us when we do anterior vitrectomy? So as you see here, the intraocular pressure is at 55. And those who are more used to the gravity-based fluidics, this equates to about 70 plus of centimeters of water, and it is indicated on the machine as well. And there's vacuum, and there's also flow rate. So what is intraocular pressure? It's actually infusion pressure. So if you look at the older systems, which are gravity-based, that's the bottle height, or centimeters of water. And this means that the higher amount of IOP, or higher bottle height, will give you a higher infusion pressure, meaning more water comes into the eye. Now, what is 350 here? This is the vacuum. So 350 refers to the holding power when you're talking about phaco, but in this case, just amount of suction you're going to get. So how much vitreous or how much fluid you're bringing into the vitrector as you are stepping on your pedal. So vacuum is the sucking power when you're talking about anterior vitrectomy. And in the Venturi system, the vacuum is linked with your flow rate, whereas in the peristaltic system, the vacuum and flow rate are controlled separately. So the vitrectomy, either in aqueous or vitreous, will give you different resistance, because vitreous is obviously more rigid, or it's more turbid, whereas aqueous is just very fluid. So understanding when you're vitrectomizing in the anterior chamber, try and clear vitreous, there will be a lot of aqueous there, or there will be some areas with no vitreous, and the vacuum and the interplay of the inflow and outflow can be different during those times. The flow rate here, as highlighted, is down to 10, and this, what does that mean? That just refers to the amount of fluid that's flowing through the tubing, so it's measured in cc's per minute. How much and how fast fluid is removed is what the flow rate refers to, and this is governed by Poiseuille's law, which looks at this complicated equation, but what you just want to highlight is the fact that R here refers to the radius or the diameter of your tubing, so that's very important. So in this case, that will control how quickly your fluid, or how quickly fluid comes to the port, and how things are removed. So the 20, 23 or 25 gauge systems are typical now in all machines, and as we know, everything is getting minimized. So again, 20 gauge hardly used anymore, and 23 or 25 gauge vitrectomy systems are becoming the norm. So if you look at the 4000 here, up there, that's referring to a cut rate. If you go back to the older machines, I think 4000 is really a very, very high cut rate, and makes it even more efficient and safe to do anterior vitrectomy or vitrectomy. In the old days, we used to get up to perhaps 400 or 500 cut rates with anterior vitrectomy, but with these newer machines and the smaller gauge ones, you can get up to 4000. So the cut rate is really how quickly the vitrector cuts vitreous. So it acts like a guillotine as you aspirate vitreous into the port, and it truncates the vitreous so that you minimize the traction on the retina. So as I mentioned, 600 cuts per minute used to be the older machines, and move up to 4000 now, and perhaps coming up even higher. So the higher cut rate you have, the lower flow you have through your vitrector, and that's just increased safety. The lower cut rate, you get higher flow. So the importance of understanding sometimes why this is important is because when you want high cut rates to remove vitreous, and you sometimes, if you have certain little bits of soft lens matter or some of the nucleus which is not too hard, you can use your retractor to remove this after you've cleared the vitreous enough by dropping the cut rate, because you get a higher flow. So this is just an animation to show how the retractor actually works. So as I said, it's a guillotine that actually cuts the vitreous as it comes into the port. This is shown in slow-mo to highlight how this is done. So in this animation, and you can see you get a different flow rate with different cut rates. And this is a cut per minute. As you move up to higher, you see how things actually come into the port. And if the lower the cut rate, the quicker the fluid comes in, so the higher the flow. Foot pedal control, I can't emphasize enough. Again, it's important to understand how you have linear control. A lot of the time, the more heavy-footed you are, the faster things may happen as you move from position 1, 2, and 3. So you can also control your irrigation with your foot pedal and your different modes as you move from cutting vitreous, or you're moving back to a bit of IA, as I will highlight later. So you got to put it all together, and it becomes a balancing act. And it can be difficult, so it's important that you understand all these parameters. As you know, PCR and having to do anterior vitrectomy for an anterior segment surgeon is not something that happens routinely. So it's important that we understand and get enough practice to not panic or to use the machine efficiently when we need to, and that's when complications occur. So we need to have adequate inflow, and this is the approximate amount, 60 centimeters of water that you need to come in. You want a low flow rate, so you drop your flow rate as much as possible, and you have a vacuum which is just enough to bring vitreous into the port without sucking things too quickly, and you want the highest possible cut rate. Now the beauty of this Centurion machine is there are different modes that you can use in the anterior vitrectomy itself, and as shown here, there's a drop-down menu where you can preset whether the settings for each mode: epi removal, IA cut. You can do peripheral edectomies or viscoelastic removal. So anterior vitrectomy obviously is the most important one. Your cut rate is immediately activated at the aspiration is on in the foot pedal. So as you step down, you will get the cut rate to cut the vitreous before to minimize the amount of traction that you have on the vitreous base on the retina. So when you want to do it is to actually, when you're removing vitreous, the bulk of it, you want to be in this mode, the anterior vitrectomy mode, so you don't actually have too much pulling forces on the retina, and it increases your efficiency as well. So the high cut rate is important when you are removing the vitreous. When you talk about epi removal, so you give you the option now to just use your cutter to actually aspirate some soft lens matter after you've done your vitreous clearance. So in this mode, the sub mode that is provided here, the settings are such that it assists in epinucleus removal, so you don't have as much cutting. As you see, the cut rate here is dropped down, but you then can able to pull on the cortical material and remove it with your cutter rather than to switch back to your IA handpiece. So you can remove all the epinucleus and OVD as well without having to switch back to your IA handpiece. Now the other one is IA cut. I actually like this mode very much. So I tend to flip between anterior vitrectomy and IA cut, and I've programmed my foot pedal to do that. So this essentially gives you aspiration before cutting. So in anterior vitrectomy, when you put your foot pedal down, you're actually cutting first before you're aspirating. Whereas in this mode, you're aspirating, and when you put your foot down all the way, then you start cutting. So this is when you start using it to remove soft lens matter and epinuclear material as well. So going between anterior vitrectomy and IA cut, I will highlight that in a video afterwards as well. So this, as I mentioned already, is for when the vitreous is cleared and you want to remove residual nuclear fragments or soft lens matter. Peripheral edectomy, I think this one is when usually I use it in the cases where I've done a intrascleral fixation of a three-piece lens, and I need to put in a PI so that there's no optic capture or not too much iris movement to actually catch the IOL. So this setting, you see the cut rate has come all the way down to 5. You have a relatively high vacuum, so you can grab a little small chunk of vitreous, and as you put your foot pedal down, it just does a few little small bites and creates a nice little small PI with your cutter. As I mentioned, this is used usually after intrascleral IOL fixation. And the last mode is for viscoelastic. I don't use this too much, but you can as well. As you aspirate, I find that when I'm using the IA cut mode, most of the viscoelastic can come as well. So in this case, your viscoelastic aspiration mode, your vacuum is set all the way high. The cut rate still maintains high just in case there's residual vitreous there. But this is only used when you've done sufficient vitreous clearance, and that's why your vacuum goes up high to suck out all the OVD. So this is a video just showing a bimanual anterior vitrectomy. I think we don't do anterior vitrectomy with one port anymore. There's always a second hand that gives you irrigation. So in this case, the left hand coming through the side port is where the irrigation is. This video here shows a pars planar anterior vitrectomy. This is my preferred method, and there's triamcinolone staining as well. As you can see, the pars planar approach I find is very safe, and it tends to pull or truncate vitreous from where it's coming from rather than pull more to the front as shown in the next video. So this is the pars planar approach, as I mentioned. To start off, you need to put in one of these trocars. I know for the anterior segment surgeon, this can sometimes be a little bit daunting, but trust me that with anything that comes with practice, this is not difficult. These trocars are easily available with the system. And triamcinolone is essential because vitreous is invisible, and putting a triamcinolone in shows and highlights vitreous very well. As you see in this pars planar approach, when you come from the back and you're cutting off vitreous where it's coming from, you're not pulling more forward, and the vitreous where you have truncated will fall back into the posterior segment. And whatever's left in the front, you can then come forward to remove it safely. So that's the pars planar approach, which is my preferred approach for anterior vitrectomy. Compared with the limbal approach, this is a case where there's triamcinolone just to highlight the vitreous. As you come through the limbus, you can see there's a little blob of vitreous that's already at the wound. And as you're removing vitreous this way, you see that more and more comes forward from the back, and essentially you're taking out more vitreous than you perhaps need to, and the eye can become hypotenuse, and you don't want that. And you're also creating more traction as you're pulling more vitreous forward. So I do prefer the pars planar approach. This is the IA cut mode I was referring to. So in this case, I've done enough vitreous vitrectomy already, and there's still soft lens matter and a PCR there. So what I do is go into the IA cut mode, go under the anterior capsule, put your foot down, pull it into the center, and press the foot pedal all the way down, and I use my left hand to crush the little small pieces of soft lens matter in as well. So this is the IA cut mode. You can also actually turn off the cutter with the kick of a foot pedal and just aspirate with your cutter as well. So just to summarize, with anterior vitrectomy, I think not so different from when we do phaco emulsification. We have to understand the fluidics because it is a different procedure, and the fluidics are a little different, and you're dealing with a smaller gauge instrument compared to your phaco tip. So you need to know your machine. I think same principles apply. You can understand how your machine functions so you can adjust settings and make sure that you can carry out the job efficiently and safely. So most of the cutters now are small gauge, and with the Centurion system, it comes with a 23 gauge system. It's a pneumatic cutter, very efficient, and it's got multiple sub-modes to help us go through the different parts of anterior vitrectomy very safely.